Hello, everyone, and welcome to today's Tuesday topic. Today's topic is improving survivor care through sexual assault, nurse examination simulation training, with our speaker today, Allison Denman, for the Philadelphia Sexual Assault Response Center. Just a quick reminder, we've always got new events that are coming up on Tuesday topics in the coming weeks and months. I don't have anything up there at the moment just yet, but there's more stuff that'll be on this site that I just popped into the chat available soon. And so without further ado, let me throw it over to our speaker. Allison, take it away.
Awesome. Thank you, Darren. Hi, everybody. Thank you so much for being here today. Really excited to get to talk very briefly with everybody just about what good can come out of improving sexual assault nurse examination training through simulation assistance. I will mention that while this is a discussion on sensitive topics, sexual assault, there is not going to be any graphic imagery. There will be, of course, discussions of clinically what happens during a forensic nurse examination, but otherwise there's not going to be any trigger warnings for any graphic content otherwise. And then this is just my little conflict of interest disclaimer. Ta-da, I have no conflicts of interest. But my name's Allison. Like Darren had mentioned, I'm the clinical director and forensic nurse manager of the Philadelphia Sexual Assault Response Center. Since 2011, PSARC is what I'll shorten it to, has been the only location in Philadelphia for adults and adolescents as young as 16 to get a forensic nurse examination after a sexual assault. And if anybody ever wants to know the rest of the history of sexual assault response in Pennsylvania, I'll provide my contact information at the end. And I'm always happy to educate more folks on what these resources look like. Outside of my responsibilities at PSARC, I'm also an adjunct professor, specifically of clinical forensic topics. I focus largely on autopsy, which I no longer do. That's another lifetime for me. But I also, of course, educate on sexual assault nurse examination, as well as critical victim studies. I also work as a certified expert witness for the local district attorney's office here in Philadelphia, as well as the state attorney general's office of Pennsylvania, where I've developed questioning protocol and training standards for attorneys in cross-examination of medical witnesses who perform forensic exams or who work with survivors of this nature of crime. I'm also a public educator because everybody deserves to know what our accessible and equitable resources are for free. And mostly a lot of that outreach that I do, other than the community at large, is mostly targeted towards our emergency responders, such as paramedics or EMTs, so that way they can also be equipped to working with this patient population in the 911 world. But out of all of those things, I myself am also a survivor of child abuse as well as sexual abuse. And I'm very happy to say that I'm also a survivor of a big cancer scare. So hooray. But a little bit of what we're going to be talking about today is a lot of conversation that's to be carried into your professional and personal lives, because a lot of you are going to have questions about a lot of the talking points that we'll have here today. And I guarantee you that you will not be the only one with questions or concerns regarding this material. I just ask, because I'm a goldfish and I'm not good at multitasking while presenting, should you have any urgent questions, please feel free to leave them in the chat. And if you have any questions that you would like to address privately, again, I will be sharing my contact information at the end of this presentation. So some of the things that we're going to talk about today is what is SANE, what is sexual assault nurse examination, and what are the training standards. We can talk about how gynecological teaching assistants or male urinary tract teaching assistants can help train people to provide forensic nursing care in the simulation setting. And then how does that actually translate to better forensic nursing patient care? And then also, what can educators and simulators do to prepare for helping and train forensic nurses that can also make a positive impact? So first, I'm going to talk about what the heck is SANE, or what is sexual assault nurse examination. I use forensic nurse and SANE interchangeably, forensic nurse being that big umbrella of all different types of forensic nurses, but we're specifically talking about sexual assault examination today. Those other types of forensic nurses would be nursing paralegals, individuals who work in the court system, individuals who work in correctional settings, as well as individuals who work in medical legal death investigation, like the coroner's office. But today, for sexual assault nurse examination, we'll go over our definitions, some of the care considerations for our niche patient population here, as well as what are the training standards for conducting this nature of exam. So a sexual assault nurse examiner simply needs to be a registered nurse. A sexual assault nurse examiner, SANE, is a practice of nursing that dates back into the 20th century. However, it wasn't really formalized into a trained profession until the 90s. That was following our Violence Against Women Act authorization back then. So registered nurses have largely been the leading source of care in forensic nursing for a lot of reasons that we're not going to talk about today. But there are also sexual assault forensic examiners, which expands the descriptive scope of care to include any advanced provider other than a registered nurse. So, for example, at PSARC, we have nurses who are master's educated. We have some who have their DNP or their PhD, but all of the care guidelines operate at the basic life support registered nurse level. So minimum standards for board certification of forensic nursing is 40 hours of didactic education plus 40 hours of a clinical preceptorship, where you're conducting exams with an experienced forensic nurse at the time. If this exam setting can include colposcopy or anoscopy, that's going to be institution specific, and we're really not going to talk about either of those advanced instrumentations here today. But something I do want to stress, though, is that these minimum training standards for board certification are entirely optional. They are not mandatory to conduct a forensic exam. Did you know that in Pennsylvania, you actually don't have to be trained as a forensic nurse to do a forensic exam in a hospital? You simply have to just have your registered nurse license. This is based on the rationale that the Department of Health in Pennsylvania expects any registered nurse to be able to open up the box of the rape kit and read the instructions inside and follow it accordingly. This does not include any type of considerations that are otherwise addressed in training, such as what is the actual focused physical examination that you're conducting? How do you perform a strangulation assessment? How do you determine what type of evidence to collect and how to collect it? What happens to the patient's medical care after the forensic exam? So what kind of post-exposure prophylaxis, for example, can we provide them? The instructions inside of the rape kit also do not include any information about discharge safety planning for those patients. So what next? What other resources can they be connected with? Where can they be discharged to safely? Do they need any other higher scope of care following the examination with your team? And then ultimately, what most forensic nurses, even our most experienced ones, have huge anxiety about is our courtroom skills. The nature of forensic nurse examination is that of a medical, legal, clinical setting. So we are providing patient care with the possibility that this could assuredly go into the legal system following investigation for potential prosecution. I will mention it's exceptionally rare, though. Only 20% of rape victims actually report their crimes to law enforcement. An even smaller 30% of that 20% are even investigated. And an even smaller 30% of the 30% of the 20% even make it to prosecution. And out of that fraction of a fraction of a fraction, only about 8% of those court cases actually conclude with a guilty verdict. Most of those patients end up falling out of the system entirely, and there can be no adjudication. So it doesn't mean that nobody's guilty. It's just that there's no complainant participating in the system. But that's a lot of stuff to know for a registered nurse who's expected to simply just open up a rape kit and read the instructions. So what else happens during a forensic nurse examination for sexual assault? The biggest focus that we have, because this is a crime of power and control, and this is very often the patient's first step into restoring their autonomy, is our considerations for patient consents and the actual verbal interview. A lot of the questions that I ask patients are going to be a little redundant with what detectives or other law enforcement might be asking the patient. But the verbal interview that we are trained to conduct is going to be very specific to the patient's body's exposure during these interactions with other people, and being able to listen to the patient in a way that is centered and trauma informed, and not only use that to dictate what type of care and resources does this patient need, but also how can we conduct and collect the evidence that we need in a way that will also be trauma informed, and not as scary and terrifying to the patient through that caring process. So more of the aspect of the forensic exam includes that physical examination based on that verbal interview, as well as the evidence collection. We provide medical treatment for our patients, including post-exposure prophylaxis to make sure that they're not getting sexually transmitted illnesses such as gonorrhea, chlamydia, or HIV and AIDS. We also provide emergency contraception, which has been a very big concern for a lot of local providers with federal changes happening as far as our Roe v. Wade protections and everything. And I can say at least that emergency contraception, especially for rape victims, is still protected and legally to be provided to patients according to Pennsylvania Department of Health law. We can also provide basic analgesia to the patients, based on what their injuries are or any other hygiene or care considerations after the fact. We can do safety planning and discharge instruction, including a lethality assessment screening to make sure that the patient, should they be unfortunately returning to a setting where somebody is there that might hurt them or reoffend them, we want to make sure that the patient knows how to get help and what resources are immediately available to them in a confidential way. And then also, of course, our referrals for ongoing care and other supportive resources. Some states have entire concussion clinics dedicated to strangulation victims, for example, but that type of resource is an immense privilege and few and far between. But imagine if we had better training standards at just the base level, what else we could engineer moving forward for the rest of the patient's recovery experience. So like I was saying, I'm not going to go through all of this wall of text because, again, this is not a SANE training presentation, but there is, just from a glance, a lot to be informed of in order to perform a forensic exam. This includes understanding what is the role of the rape kit, being able to explain to the patient what the role of the rape kit is, as well as the continuing process of DNA assessment and everything else like that. We can also look for serological samples. We're looking for body fluids. Strangulation assessments are the leading cause of death for rape victims in the United States, but they are one of the most underdiagnosed injuries following a sexual assault. So being able to conduct a strangulation assessment during the sexual assault examination, if indicated for that patient, could potentially save their life. I don't mean to sound hyperbolic, but we're preventing post-concussive injuries like stroke or delamination of the carotid structures in the neck. Lots of stuff that when we're thinking about strangulation, it's not so much of can they breathe, it's how is the circulation between the brain and the heart. And I can say out of all of my patients who have passed away in the last year, unfortunately, all of their deaths have been preceded by traumatic brain injury related to strangulation. I will also say that another major demographic in our patient population across the board are also substance-facilitated sexual assaults or alcohol-facilitated sexual assaults. And when I say a alcohol or substance-facilitated sexual assault, I mean that a patient is exposed to a mind-altering substance that renders them incapable of being able to either make an egress or make an exit, or provide consent for sexual intercourse or otherwise. The gross majority, about 75% of our own patient population at PSARC are affirmative substance facilitated sexual assaults. And one of the things that is really important for talking with patients is that a lot of times the intoxication component of it is self-sourced through consensual consumption. A lot of my patients are worried about insidious introduction of roofies or Rohypnol or other benzodiazepines, rape drugs, as they're colloquially referred to as. But as a matter of fact, those are very, very exceptionally rare nowadays for us to see. It's expensive to buy these illicit substances. And if people are simply drinking to the point of intoxication or consensually self-medicating with other substances, that is enough to render somebody potentially unable to aid themselves. And being able to professionally and succinctly document those types of concerns in the medical record is also very, very important for that patient's ongoing care, as well as their representation in the court of law and the semantics of their capacity to consent. We also use lots of different types of technology like toluidine blue dye for contrast dye on the body, looking for scratches that maybe aren't visible to the naked eye, especially for individuals with deeper skin tones. We can use black lights. I'm sure lots of folks have seen those on like Hotel Hell or the other TV shows where they throw up the black light and it's like, oh my gosh, there's guck everywhere. We have to be able to talk to our patients about what might that be if something does show up as fluorescent under that alternate light, and making sure that we're conducting this in a way that is safe. Imagine being a survivor of a crime and meeting with a clinician that you've never met with before and being asked to sit in a room with them by themselves with the lights off so they can shine a black light at you, and then you potentially seeing stuff all over the place that you're like, I didn't even think something would be there. But as a matter of fact, laundry detergents, self-tanners, a lot of cosmetics or body lotions can and do fluoresce under black light. So when I say like, oh yeah, we use black light, there's so much education that has to go into just that alone, that just waving it around is not really going to do anything except potentially traumatize the patient themselves as well as potentially the provider. And then photography. I know if you're somebody in this room who likes to have your picture taken on a good day, that's really great for you. I hate having my picture taken by anybody else. That's not me. But imagine this on potentially the worst day of your life. While also taking into the forensic rules of evidence considerations for what kind of pictures are even admissible in the court of law, and how can I best take those pictures in a way that they are representative of the subject material, they don't hold any bias, they are truly not doctored images otherwise, but still representative of the details of interest. There's a lot to be talked about in forensic nursing that simply if you open up a rape kit and read the instructions on the inside, which are only sometimes updated to current practice standards, potentially every 3 years, not always the case. We just did our first review for 7 years because the pandemic and everything else. Sexual assault stopped happening during the pandemic. I don't know if anybody else knows that. But there's so much that needs to be focused on for forensic nurse examination of sexual assault victims that can completely change the trajectory of not only the patient experience, but also that clinician's wellness and career, as well as the legal repercussions that come after the fact, should this be something that goes to court. So again, word vomit. I'm going to break it down to a lot of bad news that nobody wants to hear about. But thankfully, we're here together to talk about how can we do better. So one of the number one things that I stress in the importance of SANE education overall is the staggering fact that only a quarter of hospitals, and that's pretty a gracious estimation, only 25% of hospitals in the entire country even provide sexual assault nurse examination. even though it's written into federal law, even though it's written into most state laws, not only the necessity to follow EMTALA violations and screen and treat these patients for their injuries, but also to legally provide them with the necessary post-exposure prophylaxis. Did you know in Pennsylvania, there's a law dating back to 2008 that says that patients who have been sexually assaulted are to be provided with a free physical dispensement of HIV medications for a minimum 3-day prescription out of the rest of the 28-day supply. Most providers in the hospitals don't know that. So even if they are not performing forensic nurse examinations further beyond that, a lot of emergency department providers or providers in other settings are simply not even just doing the rape kits, but they're also not treating patients with the medically required aspects of care. The other part is that our forensic nurses are few and far between. Forensic nursing is one of those jobs where I don't think I've heard the phrase, well, you signed up for this more than I have in this career. The average career length of a sexual assault nurse examiner is only about 2 years. And that's because of vicarious trauma from working in this patient encounter, hearing and reliving a lot of these experiences with the patients in ways that even police officers do not have the privilege of engaging with these individuals. And very often, again, because we have a lack of institutional representation, we also have a lack of competent peer support in order to have a true teamwork approach into supporting each other through this. We already know that nursing is wrought with lateral violence. This is the last place that we need that. But unfortunately, one of the things I'd like to point out is, even though, again, this is probably a grossly undersized statistic, but no less than 65% of healthcare professionals have entered the healthcare realm with some history of trauma or violence in their life. And if not them themselves, then by a degree of one, like a sibling, a parent, or otherwise. And that's what motivates a lot of us to get involved, is that we want to be helpers in the way that we needed help when we were younger. Unfortunately, the blessing of that empathy and that perspective comes from a place of violence, and unfortunately puts those of us with those histories into positions to be more readily traumatized in the future. And that's because our bodies have changed, our brain chemistry has changed. And even though we have maybe made our survival for years and years and moved on, we are still going to react to these traumatizing events very differently than any of our healthcare peers who have never had the misfortune of experiencing something like this. One of the other issues is like, well, Allison, why don't we just dump more money into forensic nursing resources? Like, where's the government? We have the Violence Against Women Act. It was just reauthorized last year. Well, all of the federal funding for forensic nursing is completely controlled by the Department of Justice. None of it is under the Department of Health and Human Services. And if you live in a state that does have forensic nursing services, only sometimes is there guidance through your local Department of Health, but very rarely is there any funding available through there, despite the legal requirements of medications to be provided and all that good stuff. But this places a strange predicament onto clinicians who are really trying to mobilize these resources, because what do we do for patients, or how are we funded for patients who maybe are reluctant to work with the law enforcement system or the legal system, but still legally required and absolutely necessary medical care? So we have no appropriation of medical emergency services under a federal department that is all cops. Another thing that we have, I already mentioned anonymous patients, but those same anonymous patients who have the legal right to not make a police report as an adult victim, a lot of the resources that regular survivors in our community would have access to are simply not applicable for these patients anymore. In Pennsylvania, we have something called the Victim Compensation Act, where patients can receive up to $35,000 in reimbursement for medications, surgeries, funeral expenses, all of these things. But it only is applicable to patients who have a police number. So anonymous patients, even though they're also protected under law as victims of sexual assault and to be provided with medical care. Because it has no prosecutorial value, the Department of Justice does not prioritize funding of resources for anonymous patients. And again, that's an ethics discussion for a whole other day of lecture. But just think about from the case management perspective, what does this mean for our patients? And one of the other things that we have to consider is that even in the hospitals, for all the training that hospitals offer for phlebotomy, lifting, CPR, all of these different things, it is very rare that hospitals ever provide training on sexual assault examination or even just pelvic assessment training for registered nurses. And it's usually deferred to advanced providers who have no forensic training. But even further, nursing schools very much do not offer a lot of information in the didactics of their core curricula for nurses. In the undergraduate setting, you might get a day where they'll mention like, oh, and there's forensic nursing, and it's usually listed under behavioral health or something like that. And then we never hear about it again. When I was a nursing student, our instructor defined a forensic nurse as someone who can determine whether or not a victim is malingering, which means lying with the purpose to elope legal complications. And I'm like, no, I definitely don't do that. I'm flattered, but thank you. But the other issue that we see here is a lot of nursing colleges also mistaking the role of the forensic nurse and saying, oh, if you want to be a forensic nurse, you have to get your master's degree. That's simply not the case. You just need your registered nurse. You could have your associates. You could have your diploma in nursing. As long as you have a registered nurse license and you are being placed into a setting where you are to provide this legally required care, it doesn't make sense that this isn't a baseline functional opportunity for nurses to volunteer and to be trained. So what happens when the forensic exam goes completely sideways? This person's already having a nightmare of an experience. And one of the things that we know as health providers is one of our responsibilities is to do no further harm. This person's already been hurt. Thankfully, we were not responsible for that, but we want to make sure we're doing our due diligence to initiate that healing process. Television does a really great job at fear-mongering the sexual assault nurse examination experience. So a lot of patients come into the setting already suspicious that this is going to be a traumatizing and lengthy event. So we can have potential injury to the patient because the clinician doesn't know how to use instrumentation like a black light and not giving the patient the correct eye protection to wear during the black light assessment, or not knowing how to use a speculum when doing an internal assessment of the vaginal structures. A lot of times, an ineffective forensic encounter could also mean that nobody's talking about what happens next. So safety discharge planning is disregarded. There's also the potential lack of identifying and documenting injury, which means that consequent harm can happen to the patient because they don't have the care being provided to them or the necessary discharge instructions to continue healing when they don't know what types of injuries they do or do not have. And this is particularly important for our high-risk patients who have deeply melanated skin tones, so Black and brown patients in particular. We also have the potential lack of identifying and collecting evidence, where before we were compromising the patient's literal health recovery, now we are potentially compromising the judicial process, where we're either collecting the wrong information, documenting it incorrectly, stressing significance on things that are not legally pertinent to the patient's experience. Lots of things can go sideways in that regard. But also for the provider themselves, they can also have potential secondary trauma, not only to the patient for obvious reasons of just incompetent medical encounter, but also the fact that the provider, knowing that 65% of us are coming in with previous trauma experiences, a lot of us come in with that heightened sense of guilt and saying, oh my God, what else could I have done? Even if we've done everything correctly and to the fullest extent for our patients. So we have a lot of forensic nurses who struggle with secondary trauma because of their own self-perceived incompetence. We also have resource considerations for the patients being disregarded. We had an issue before where a patient from a hospital came to us with a printed list of shelters saying, oh, the hospital told me I could go to any of these places after I leave your clinic. Some of those clinics or some of those shelters weren't even for this person's gender. Not all of them are open 24/7. Some of them have screening considerations to be taken in. So lots of resource and case management can be ignored. And then we, of course, also have just the obvious malpractice issue with the risk to the provider's license and professional liability. And that's usually what most people are really concerned about. So next, I'm going to talk about what is it that gynecological teaching assistants and other simulators in the simulation space, how can that involvement in forensic nursing training make a difference? So we'll talk about the components of SANE training for that simulated patient engagement. What are the goals for that simulated patient care? And then how can simulators themselves actually prepare for that type of learning environment? So one of the first things that most people report back to me as the most valuable aspect of formal forensic nursing training is patient interviewing skills and communication skills. It's already hard enough to talk to other human beings on a regular basis. So now we want to make sure that we're doing our due diligence to provide patient-centered and trauma-informed vocabulary in making sure that not only are we clinically taking care of this patient, but we're doing our due diligence in legally representing them as a victim. So this simulated training can include considerations for talking to somebody whose neurobiology has been affected by trauma. We have our fight, flight, freeze, and fawn responses for when there's an allegorical bear in the room. You can either fight the bear, you can play dead from the bear, you can run from the bear, or you can try to feed the bear and become its friend, so that way the bear won't hurt us anymore. But how does that translate to making sure that the patient knows that they are in a safe environment, that their anxieties are still tremendously valid, but taking into consideration that the way that they are recalling events while their brain is in that overdrive mode, they're not going to be able to provide you with a very good recollection of a timeline, for example, because the brain is focused on surviving, not recalling. So working with a GTA or a MUTA can help us practice with talking with patients who maybe they need a little bit of redundancy in the questions. Maybe they need a little bit more elaboration on what we're talking about. Where in a normal day, I'd be like, everybody knows about pelvic exams. But in that moment, that person's like, I don't know anything about anything except I want to go home. So we also need to have a discussion about how do we practice sensitivity awareness, particularly for diversity and inclusionary considerations. Our patient population is very rarely ever what you see on TV in like a Lifetime movie network. A lot of our patients are coming to us as people who have substance dependency diagnoses, and they're actively withdrawing in the patient care setting, or maybe that substance use is part of what facilitated the violence to begin with. A lot of those patients in particular might go home and cope the way that they know how to cope, which might be more substance use or high risk activities otherwise. I'm not going to sit there as the clinician and go like, you know better, because I know that a lot of these risk factors come from a place of previous trauma, and people can only heal in the way that they know. So how do I make sure that I'm working with all patients who maybe don't look like me, don't have the same privileges as me, but are still valuable and worthy human beings deserving love and attention? And then the other thing, too, is making sure that when we're talking to a patient, some nurses struggle with this in any setting, but especially a forensic patient, we have the risk of dehumanizing this individual, not just as a medical record number, but now there's the additional dehumanization of this person as the corpus delicti, or in Latin referred to in the judicial system as the body of crime. We're treating this entire person as a crime scene. It's very easy to lose the heart in the process. We also want to make sure that when we're physically engaging with simulators, that there's a stress on learning how to conduct examinations that are safe for all bodies. A lot of folks wrongly assume that all sexual assault victims are cisgendered women. That's simply not the case. We see patients all across the gender spectrum, all across the sexual orientation spectrum, all across the lifespan. We have patients as old as their 90s that come into us. We have patients who have physical restrictions as far as their mobility considerations go. But everybody is deserving of receiving baseline accessible care. So how do we promote that? We want to make sure that we know from a baseline, what is it that is the anticipated typical, but what is also our other normal variations that we see during our physical exams. Very often, some things can be mistaken for traumatic or pathological, but they're simply just this person's body on a regular basis. So how are we talking with the patient about their body without making them feel targeted and different and everything else like that, while also making sure that our clinical interpretation of our findings are true and accurate to our observations. We also want to make sure that for accommodating patients who cannot be typically positioned into a seated position independently, how else can we comfortably sit a patient for a forensic examination, particularly the pelvic examination portion? Or maybe sometimes these are patients who don't need the physical accommodation because of their ability, but rather for their own comfort. Like, hey, when I sit like this with my knees apart, I'm feeling really anxious right now. Would it be okay if I sat up with my legs together, like crisscross applesauce? Can I lay on my side? Lots of different opportunities to make sure that, again, this is a stress on a trauma-informed environment, especially considering the pelvic examination in this sense. And then we also, of course, want to think about what language and etiquette and more are we using in real time. A lot of us nurses have issues with infantilizing patients. We call everybody baby, honey, sugar bush, whatever comes to us because we're in that mindset of caring. But we want to make sure that we are being clinically professional, that we're demonstrating that professional attitude to our patients, while also avoiding language that could be potentially triggering. For example, using a pelvic examination chair, we never say stirrups, we say leg stands or feet stands. Saying stirrups can make the patient feel like, oh, that's for a horse. It feels a little bit more animalistic. Anybody who's ever had the beautiful experience of a pelvic exam in a normal reproductive health clinic can probably think of 1,000,001 things that you're like, gosh, I wish that they would never say or do something like that again. But definitely that pays forward in this setting as well. The specialized equipment, of course, goes without saying that it is necessary for folks to learn how to use this safely. Speculum examples are an instrumentation example that's common is our speculum use. So the duckbill device that goes inside of the vaginal introitus to open it up, and we can see deep into those structures as well. That's a terrifying thing to do to anybody. We joke and we call them medieval torture devices on a good day. So now we're learning how to use these in a forensic setting where maybe this patient is having injuries. They have embedded objects in the vaginal walls. Maybe there's a lot of debris otherwise. What can we do to safely utilize the speculum from a normal basis? But you can't take into consideration for all those other specialty uses until you know just how to use the dang thing. We also demonstrate how to use toluidine blue dye, not on simulated patients, though, that are alive, because I can't cut somebody up on purpose for a learning environment. Maybe way back in the day when most of us were in school, but we don't do that anymore. But there are other alternatives with other simulation tools, like simulated body parts, mannequins. I use oranges to better demonstrate how to use a device like this. Toluidine blue dye increases injury identification by no less than 55% in patients, especially for folks with deeper skin tones or very redundant genital tissue. And again, we're focusing on making sure Did I find the injury so the patient knows how to take care of themselves once they leave here? They have the right resources to address that? And am I documenting this injury as forensically pertinent for this individual? But we can't do any of that if we don't know how to use, toluidine blue dye. And again, this is a stress not only for the comfort of the patient and the clinical component of it, but this is also affirmatively taking care of all persons who are coming in many different aspects other than the obligate hands-on medical care. So there are a lot of considerations to take in mind for preparing to either assist or to teach a SANE simulation training, or if you would like to bring that type of training to your own institution, what are some questions that you should be asking yourself, and how does that translate to the service delivery? So simulators should ask themselves, what do I know about SANE care? Have I ever watched a forensic nurse examination before? Do I know what types of patients are typically taken care of in a SANE exam? What type of medical interventions take place in a SANE exam? So all of the really basic hands-on stuff, everything that's like our equipment and everything else like that, that's our first question. But one question that a lot of us don't ask ourselves, but in the flavor of self-care, but really structuring our self-care into our institutional resources rather than having that onus placed entirely on ourselves as educators. What are your boundaries for being involved? If you are going to be a patient simulator, so a gynecological teaching assistant, are you okay with somebody doing speculum insertion on you? Are you okay with the students swabbing certain parts of your body, but maybe not other parts of your body? Are you okay with role playing, or maybe are you just here to demonstrate the instrumental demonstration? And then also, again, for individuals more so who are in the role play category, who is it that you are representing in the simulated care? It's very easy to accidentally write simulated scripts that can be triggering to the actor, triggering to the students. It could show some kind of bias or some kind of stereotyping, for example. So we want to make sure that if there is a role play component, how is that being represented in that setting, and what is the purpose of that role play? So some of the questions that educators or simulators can also ask the training center, or whatever institution you're working in. First, who is the target audience in this training session, and what is their level of experience in this field? Are these nurses who have maybe done forensic exams before and this is a refresher? Are these new to practice nurses entirely and they're fresh out of a registered nurse program? Are they reproductive health specialists working in a hospital setting? Who the heck is it? What do they already have in their toolkit? And maybe what do we need to prepare, just considering those different levels of experience? What type of equipment is going to be provided? And are those tools that you, as either the simulator or the educator, have actually used before? Are there any other special tools that I would be comfortable with simulating practice with, but maybe I haven't used before, like swabbing techniques, the toluidine blue dye, black light, the alternate light source imagery, and so on and so forth? Are there any specific scenarios I'm being requested to simulate? So some people are like, hey, I really want to know how to do a forensic exam on somebody with a penis. I really want to learn how to better conduct a strangulation examination. I want to practice working with a patient who's nonverbal. Lots of really horrible but necessary scenarios can be created for these special considerations. So just type of thinking in advance, what is something that still fits within the box while still giving people the opportunity to understand that anything can happen in these patient presentations, but we want to be prepared for as much as we can. And then also, what are the support measures in place for learners as well as instructors and assistants? My most recent forensic nursing training that I had a nurse who actually had to step out of the simulation training space because we were demonstrating a strangulation assessment. We hadn't even done anything involving the trainer's actual body themselves, no simulation, and we would never pretend to strangle somebody in that setting. But this nurse, just thinking about it and her own experience with trauma herself in her life, she's like, I never thought I would be affected just by somebody talking about this, because I thought that I've healed from this. And, I'm a boss, so I don't know why I'm so emotional. I'm like, listen, this is not normal. Like, none of this is normal. The trauma that you experienced is not normal. The recovery that you've had to do yourself is not normal. And now coming into a learning environment, handling the trauma of others while we're essentially playing pretend as best as we can is also really not normal. So being able to really enable a safe space, that capacity to provide trauma-informed care first has to start with a trauma-informed learning setting. So do you have somebody who knows how to de-escalate somebody who's maybe having a heightened anxiety response in the learning environment? Do you have a space where these learners can sit down and decompress themselves? Just people react emotionally to really horrible things, understandably. And again, with the notion of changing that displacement of self-care onto others rather than ourselves as the institution, we want to make sure that that curriculum and the physical space for learning is enabling that person to actually be cared for, rather than leaving them to have to leave and take care of it themselves. So some of the careful context that is very much brought into this type of setting are a lot of polarizing topics that even some clinicians hold certain biases in. So this can be patient diversity and recognition of hate crimes or their bias-motivated violence in our communities. We have a lot of providers who have bias against patients who decline to make a police report. A lot of folks will say something like, well, if it was so serious, then why don't you just make the police report? They're here to help. But being able to understand what are the parameters of referring a patient to these services and what resources do they have access to in the meantime means care for everybody, regardless of your opinion on law enforcement. We also have folks who are polarized over emergency contraception, patients who are coming to us with substance dependency issues, or patients who self-medicate with illicit substances, patients who might be trafficked or consensually involved in sex work as well can be polarizing for providers. Patients with complicated citizenship or language barriers, for example. We are a refugee city here in the city of Philadelphia, so we work with a very large melting pot of cultures here. So being able to make sure that we're also demonstrating cultural competence while also honoring the risk factors of individuals from marginalized communities in these settings, it's so important from a survival perspective to take care of these individuals. And then again, tying into the law enforcement thing is also the right to anonymous reporting, but also understanding our right as clinicians. How are we educating our patients on this consent process and what happens after they leave and maybe they change their minds? So how does all of this contribute to making forensic nursing services better? Not just from the patient perspective, but also from the learner and the provider perspective. So this means that we're going to have enhanced clinical awareness of restorative care. Justice is seen as retributional or restorative justice. Retribution is the law and order, crime and punishment side of things, where restoration is how do we get this person back to where they want to be safely? Not who they were before, because they'll never be that person again, but who can they be next and how can they find that pathway safely? We also promote patient autonomy after an exploitative event. because again, this is a crime of power and control, not of romantic impulse. So the least that we can do is demonstrate that autonomy and independence in the clinical setting. We're keeping physical engagement with the patients, trauma-informed and concise and intentional. We're ensuring fluency of patient-centered language. We're creating an inclusive and anti-racist setting for providing patient care. And all of the above enhances better patient engagement, delivery of care, and evidence collection just across the board. So some of the allegorical examples I have to share from learners who have been SANE trained in a simulated space. This is from our own simulated space, but patients are typically taken care of by a provider who is SANE trained with GTA or MUTA assistance, have a more comfortable patient experience overall. These learners also said that injury identification and documentation samples from providers who are SANE trained are much improved at a baseline. These learners also have verbalized that they are more confident in caring for all patients, not just forensic patients. And one of the things that I want to stress with that point is that even if you're not doing a forensic exam, I guarantee you in whatever space you may be working in, somebody might disclose to you that they had been sexually assaulted or affected by violence in some other way. And the least that you can do is your due diligence in getting them to the correct resource. So while we're taking better care of all patients, now we also have a good baseline of understanding of how to also resource these patients. These learners also verbalize that they are more confident in specialty instrumentation like speculum use. They had an overall improvement on quality investigation and prosecution outcomes. So that just means that they're being utilized more often as fact witnesses in the court system, which is still very new for a lot of our jurisdictions, but we're really enhancing prosecutorial outcomes by bringing expert nurses into these settings. And we also have, and this is like my bummer, the burnout from vicarious trauma is delayed. It is not cured. This is still assuredly a very violent and unfortunate patient encounter. So I can't say that there is anything that would prepare all nurses, all medical providers to be absolutely the Superman with all of the answers for our patients and not take some of that home ourselves. I have done forensic examinations in my career now on over 400 patients, spanning all across the lifespan, including neonates, including centurions, and everybody is so different. And I like to remind folks that just as much as there are different ways to love people, there are just as many ways to hurt individuals. So this is one of those settings where you say, like, I think I've seen it all. You definitely have not, and that's okay. But one of the things that's really important with leading a trauma-informed classroom and trauma-informed patient care is that these nurses are going out with better capacity to cope. They have better de-escalation skills to make patients comfortable, and therefore they are more at ease in engaging with these patients. The obscurity of the unknown of what happens next is something that can, in this setting, be resolved a little bit for nurses, especially when talking about institutional communication and sexual assault response teams, talking to law enforcement and everybody else like that. But again, this is just a very small drop in the water in protecting our nurses and doing what they do best, and that's trying to help. And so if this is at least something that can make that a little bit more better, then that's a job well done. That is the presentation. We have a couple minutes for questions, but I do want to put my email address in the chat for anybody, again, who wants to follow up with me with anything confidential. I see Laura. Laura, I have to get back in touch with you. I've been a very busy girl. I see, how can you get an evidence collection kit sent to your facilities in Pennsylvania if you don't already have them? Is this something free sent from the state? Law enforcement actually pays for them. Hospitals can buy them themselves, but law enforcement typically has a better, what I want to say, like relationship with the suppliers. because they're the ones who are buying more of the equipment. They can usually also get bundled discounts when buying lots of stuff in bulk that we won't use. But in Pennsylvania in particular, if you have a patient who shows up to your hospital and you don't have a rape kit, law enforcement is actually supposed to bring you one. But one of the issues that we have here in Pennsylvania beyond hospital noncompliance is that law enforcement, with as many jurisdictions as we have, not all of them are on the same board with compliance and being able to provide those resources. But I can follow up with you and figure out what I can do for you locally then. Any other questions? And again, my email's in the chat box, ald376@drexel.edu. Please feel free to touch base. And I promise no question is a dumb question because this is a horrible thing. So thank you.
Allison, there's one more question about syphilis increase.
Syphilis increase. So Pennsylvania is a boiling pot for STIs across the board. I don't have any information that I can really say about syphilis in particular from our setting because it takes so long to diagnose somebody with syphilis that in the primary forensic setting, within 5 days, we're typically not providing a lot of focused attention onto that. But I can say that for some weird reason, a lot of courts have been bringing up syphilis and how syphilis develops through the disease process. So stay tuned. I'm sure that we're going to probably start implementing more focused conversation into that also. But right now, there's really not a lot of standardized information about syphilis regarding specifically forensic patients. So sorry for the non-answer, but I hope I have something better for you soon.
All right. Well, thank you, Allison, for a great, very informative presentation. It's great to learn about the work that you do. It's very important. And we're grateful that you could join us today at Tuesday Topics.
Awesome. Thanks, Darren. Thank you, everybody.